Welcome. Today we're doing something a little different. We are going to simulate a surgical board exam, a viva, focusing on a classic scenario, the liver mass. I'll be playing the examiner, but I'll also be walking you through the consultant-level thinking you need to absolutely nail this kind of case. So, let's get started.
All right, you're the candidate. Here is your opening line, a 45-year-old with right upper quadrant pain. Now, this is a super common presentation, but the list of possibilities is huge. Your first move here is absolutely critical because it tells the examiner right away if you're a safe, systematic doctor. So let's hear it. How do you proceed?
My approach would start with the absolute fundamentals, a really thorough history, followed by a detailed, systematic physical examination. I need to gather all the clinical data I can before I even think about ordering a single test.
Exactly. This approach shows you're a clinician first. You're not just someone who orders scans. You're building a clinical picture from the ground up. So in that history, I'm really drilling down on the pain. Is it sharp? Is it dull? Is it constant? What about other symptoms? Fever, weight loss, anything like that? And of course, you have to ask about risk factors. Any recent travel? What's their alcohol intake? Are they on any medications? Specifically, the oral contraceptive pill.
Okay, then it's time for the physical exam. I'm going through the 4 classic steps. First, I'm just looking. Inspection. Do I see any old surgical scars? Is the abdomen swollen? Or do I see those prominent veins we call a caput medusa? Then, palpation. I'm carefully feeling for where it's tender or if there's a mass. Percussion helps me map out the size of the liver and check for any fluid or ascites. And finally, auscultation. Just listening for bowel sounds or any abnormal vascular sounds called bruits. You have to be structured so you don't miss a thing.
And you know, the liver is not an island. Its health affects the entire body. So I'm also looking everywhere for the systemic signs of chronic liver disease. You check for jaundice under the tongue, look for spider nevi on the chest, check for gynecomastia, and look for swollen legs. All these clues help build a picture of the patient's underlying liver function, which is just crucial information to have.
Okay, great. So, your exam has a positive finding. The patient has a palpable, tender liver. Now I want to know how you're going to investigate this, and I want to hear a logical, cost-effective plan. What tests are you ordering and in what order?
My investigations are going to be stepwise. I'll start with baseline blood tests and then move on to specific imaging. The goal is to characterize whatever this lesion is and start building a solid differential diagnosis.
So that first round of blood work is going to give us a ton of information. A complete blood count might show a high white cell count, which would point towards an infection. The liver function tests, or LFTs, tell us if the liver cells are inflamed or injured. A coagulation profile tells us how well the liver is doing its job of making clotting factors. From there, we can get more specific with serology for things like amoebas or Haydated disease, and of course tumor markers if we're worried about cancer.
For imaging, I'm starting with an abdominal ultrasound. It's easy, it's non-invasive, and it's fantastic at the first big question. Is this thing solid, or is it a fluid-filled cyst? Based on those findings, the real workhorse for liver masses is the triphasic CT scan. An MRI or MRCP? I'm saving those for problem solving. Or if I need a really detailed look at the bile ducts.
And there it is, a classic viva question. The examiner wants to see if you can think broadly, but also organize your thoughts. Just rattling off a random list of diseases is not going to cut it. You need a system.
I would categorize my differential diagnosis to make sure I cover all the bases. So we can break it down. First, is it infectious? Things like a pyogenic abscess or a Haydated cyst. Second, could it be benign, like a simple cyst, a hemangioma, or an adenoma? Third, could it be a primary cancer that started in the liver, like hepatocellular carcinoma? And finally, you have to consider secondary or metastatic disease, which is actually the most common type of liver cancer, often coming from the colon.
Excellent. That is a really well-structured differential. Now, let's narrow it down. I'm going to give you some specific findings.
All right, candidate, there you have it. The imaging findings here are pretty much pathognomonic, and you've got positive serology to back it up. So, what is the definitive diagnosis?
With those findings, the diagnosis is a Haydated liver cyst. This is a parasitic infection from the tapeworm Echinococcus granulosus. We humans are just intermediate hosts, and the liver is by far the most common place for these cysts to show up, with that daughter cyst appearance being the classic sign.
Now, it's really important to know how to tell this apart from other infectious cysts. For example, an amoebic abscess, that's caused by a different parasite, a protozoa, and it typically doesn't have daughter cysts. Plus, patients often have a history of diarrhea.
If you were to aspirate it, you get this thick, reddish-brown pus that's classically called anchovy sauce. Knowing these distinctions is absolutely vital for management.
Correct. So you've nailed the diagnosis. Now for the most important part of any viva. What are you going to do for this patient? Walk me through your management plan.
The management for a hydated cyst is tiered, like a ladder. For very small, uncomplicated cysts, you might just use medical therapy alone with a drug called albendazole. For other suitable cysts, there's a minimally invasive technique called PAIR. But for a case like ours, a large, complex cyst with daughter cysts, surgery is still considered the gold standard.
I'd recommend surgery for this patient specifically because of the large size and the fact that it has multiple daughter cysts. Other clear reasons to go to surgery would be if the cyst was complicated, meaning it had ruptured or gotten infected, if it was causing pressure on nearby organs, or if it was located very close to the surface of the liver, putting it at high risk of rupture.
And this brings us to an absolutely critical safety point. This is a big one for exams. You have to give the patient albendazole both before and after any procedure. Why? This medication helps to sterilize the cyst from the inside, which reduces the risk of it coming back, and maybe even more importantly, it reduces the life-threatening risk of anaphylactic shock if any of the cyst contents spill during the operation.
Very good. You've managed this specific case very well. Now, for the final part of this viva, let's just touch on a few other common liver lesions. I want to test the breadth of your knowledge.
Okay, two benign tumors that always get confused are hepatic adenoma and focal nodular hyperplasia, or FNH. The key difference you have to remember is malignant potential. FNH has no malignant potential. It's benign, we watch it. Adenomas, on the other hand, which are linked to oral contraceptive pills, carry a risk of turning into cancer. That's why we generally resect them if they get bigger than 5 centimeters.
And that 4.2% figure, that's the number that drives our decision-making. It might seem small, but it's a significant risk of developing hepatocellular carcinoma. And it's exactly why we have that aggressive surgical approach for any lesion bigger than 5 centimeters.
And here is one of the biggest red flags in all of liver surgery, something you must never, ever forget. You do not biopsy a suspected hemangioma, and you do not biopsy a suspected hydated cyst. If you stick a needle in a hemangioma, you risk catastrophic bleeding. And as we've already discussed, if you puncture a hydated cyst outside of a controlled procedure, you risk anaphylaxis and spreading the disease. This is a massive patient safety issue.
And for the final question, a test of some pretty deep knowledge on rare but deadly syndromes. A giant hemangioma can cause a consumptive coagulopathy, where all the patient's platelets get used up. What is this syndrome called? It's Kasabach-Merritt syndrome, a condition with a very high mortality rate that every single surgeon has to be aware of. And that concludes our viva on the liver mass.